Good afternoon and welcome. My name is Tim Poe and I'm the Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, January 22nd, 2020, for our Research to Practice lecture. And just a few things to go over and then we'll meet our guest and get started. If you're having any technical difficulties, you know the drill, 919-445-1000. You can email us unccn@unc.edu. We do want to say thank you to our doctors, nurses, pharmacists, radiologic technologists, and the many others who attend these lectures, and for all the vital work you do to care for cancer patients here in North Carolina. We are always extremely thankful for that. So let's take a look at just a few things here. We will be using Poll Everywhere today, just like we do every lecture. So two easy ways you can, and actually three that you can use to join us with Poll Everywhere. You can go to a web browser, any web browser, go to pollev, POLLEV.com, enter the letters UNCCN, and then you'll see the questions and be able to respond to those as we go along. There's also an app, and you can download the Poll Everywhere app, and that's another easy way to join us. And finally, if you want to use just texting, you can go ahead and text the letters UNCCN to the number 22333. You'll get a message back saying that you've joined, and then you can go ahead and put in the letters that correspond with the correct answers, and then at the end you'll be able to share your questions. Please be thinking about questions throughout this presentation and then sharing those with Dr. Wang, and he'll address as many of those as he can at the end of our presentation. Just to let you know, everything we do is free to you. We have free CNE, CME, ACPE, and ASRT credits, live lectures second and fourth Wednesdays, and then all of our courses go online where you can take them for about a year and receive credit that way as well. We've got a free media site library where you can go and see the lectures without receiving credit for them. We're on YouTube, and we're now on ViewMedi, and we're excited about that. I'll talk more about that soon, but that's another place where you can view our lectures starting in 2020. Okay, so without further ado, I would like to introduce our guest, young Wang Md Phd. Thank you so much for being here today.
Happy to be here.
Thank you. Let's see what we know about you and then maybe find out even a little bit more. A medical oncologist specializing in treatment of genitourinary malignancies. Completed residency and fellowship in hematology oncology, as well as postdoctoral research fellowship. Mm-hmm. Long-term research interest has been in understanding the mechanisms underlying therapy resistance of advanced prostate cancer. So you're the right person for our prostate cancer lecture. Has been conducting clinical and translational research in advanced prostate cancer and has been treating prostate cancer patients for over 20 years here at UNC. Well, thank you. We are so pleased to have you here. What's something that else that we should know about you outside of the professional realm?
Well, I'm an avid Tar Heel basketball fan, and this year I got the season ticket for the first time, and it's been a bit of a disappointing season.
Well,
but I predict that Roy Williams will pass Dean Smith's record sometime this year.
Great.
Not next season.
Well, we'll hold you to that. We'll have to bring you back to see what happens there. Thank you. And I mentioned Poll Everywhere, so this is a preview of our first Poll Everywhere question. Which of the following statements about prostate cancer is true? Prostate cancer only occurs in women, A, or prostate cancer only occurs in men, B. Hopefully this first question is kind of a softball just to get you engaged in using Poll Everywhere, so we'll look at that in just a moment. And while you are going ahead and filling that out, I will say that this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Professional Development. Dr. William A. Wood, MD, MPH, receives research support from Pfizer. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Young Wang, MD, PhD, has no financial relationships with commercial interests. Phew. All right, got that out of the way. Let's take a look. Here's our first poll. We've already had several people answer it. We'll wait just a few more seconds to give anyone who has not already answered that an opportunity. If you run into any trouble with Poll Everywhere, again, call that number or email that email address and let us know. But that should be working just fine. Dr. Wang, how are they doing?
I think they're doing great.
Good.
Everybody
good.
got it right.
Terrific. All right. Well, without further ado, prostate cancer management in North Carolina updates for 2020. I'm going to, before you start, I want to make one minor modification here in the studio so that you can see the top of the screen a little better. There we go. All right. Let me pass the keyboard and mouse to you, and you're ready to go.
All right, let's get started. So my topic today is recent advances in management of advanced and metastatic prostate cancer. And this slide shows the natural history of treated prostate cancer. So as you all know, prostate cancer is the most commonly diagnosed cancer in men, and they are treated with curative intent with surgery or radiation, and or many patients may not need treatment. But anyway, eventually, some patients may relapse with rising PSA, and eventually, left untreated, they will develop clinically metastatic disease. And then at that point, androgen deprivation has been the standard of care. And the PSA is used to monitor their response to therapy. And as long as PSA remains not rising, then they are considered to have hormone-sensitive prostate cancer. But unfortunately, over several years, maybe with an average of about 2 years, all patients will develop castration-resistant disease. And this is a terminal stage, and they die from prostate cancer. But fortunately, it takes many years for this full course to take place, and they also die from other diseases as well. Occasionally, some patients will present from get-go with metastatic disease. And we think that these patients actually have a much worse prognosis. And recently there has been a trend toward intensifying treatment. So this is our main topic today. So let me start with a case presentation. This is actually a very typical patient that I see as new patients in my clinic. A 75-year-old man presented with urinary obstructive symptoms. And the primary care physician found that digital rectal exam was normal. And then PSA came back high at 147. So the patient was sent to a urologist, and a prostate biopsy showed prostate adenocarcinoma with a Gleason score of 4 + 4 = 8. 6 out of 12 cores were involved. And CT scan of abdomen and pelvis were unremarkable. But bone scan actually showed 3 foci of uptake in the spine, very much suggestive of bone metastasis. So what treatment is indicated? So what is the first treatment? Should it be surgery with prostatectomy, radiation therapy, or chemotherapy with docetaxel, or hormonal therapy with androgen deprivation? I'll give you a few minutes to answer.
Yeah, thank you all for your quick responses, and just a reminder that this is completely anonymous, so it doesn't no risk in making your best guess on what the answer is here today. And got lots of the audience participating. Dr. Wang, how are they doing?
Well, I think that maybe half the people got it right. Okay. The hormonal therapy with androgen deprivation therapy is actually the current standard of care for any patients with metastatic disease, especially if it involves the bone. Mm-hmm. So let me go on to the next slide here. Okay, so this gives the current state of the field for how we treat patients with advanced or metastatic prostate cancer. So androgen deprivation therapy initially with surgical castration was discovered 80 years ago, but for past 50 years using LHRH agonists like leuprolide or antagonists like degarelix has been the mainstay of the treatment, and that was all we did. And then when patients develop castration-resistant disease, the next treatment to be developed was standard cytotoxic chemotherapy with docetaxel, and then cabazitaxel. But about 5-7 years ago, there has been a development of androgen receptor signaling inhibitors, typically divided into two classes. One is called a CYP17 inhibitor, exemplified by abiraterone, or an anti-androgen. The oldest form is bicalutamide, but now the novel anti-androgens, there are 3 of them, enzalutamide, apalutamide, and darolutamide. And all these drugs, the CYP17 inhibitor and novel anti-androgens, have been associated with marked clinical benefit in the treatment of castration-resistant disease. And then another drug that's actually used quite a lot, at least in my practice, is a bone-targeted agent, radiopharmaceutical agent called radium-223 that delivers nice amount of alpha particle radiation to the bone, and patients benefit from their painful bone metastasis. Anyway, I'm going to be talking primarily about the chemotherapy, actually mostly about androgen receptor signaling inhibitors. So to give a brief overview of how these agents work, I have a schematic here. So this depicts the inactive androgen receptor without ligand. And then over time, the tumor cells actually pick up the ability to synthesize the ligand dihydrotestosterone. So the cells take up the steroid precursors like cholesterol, and then CYP17 enzyme is actually the rate-limiting step to produce testosterone, which gets converted into dihydrotestosterone. And when androgen receptor binds to dihydrotestosterone, it dimerizes, it translocates into the nucleus, it binds to the DNA, and then it promotes transcription of target genes like PSA. And the abiraterone is a drug that inhibits CYP17, and it depletes the cells of the dihydrotestosterone, whereas anti-androgen like enzalutamide and apalutamide prevent binding between dihydrotestosterone and androgen receptor, and it prevents all the subsequent steps like translocation into the nucleus, binding to the DNA, and it decreases the synthesis of PSA. So as a way of introduction, I'm going to ask a question. So this is the same case of patients who presented with metastatic prostate cancer with a 3 foci of uptake, 3 foci. And the question I want to pose is that what is the metastatic volume category? And I will be very impressed if you get it right. So it could be low volume disease, intermediate volume disease, high volume disease, or additional information is needed to stage this or make a decision on this question.
And thank you again for having so many of you participating today in the polls. We really appreciate that Dr. Wang has come up with several questions for you today. So be ready for more, and again, be ready to ask your own questions at the end. Well, Dr. Wang, how did they do this time?
Well, the correct answer is low volume disease, and I'll go over the reason why we actually even talk about it. And frankly, if I went to ASCO and ask this question, I expect maybe that half the practicing oncologists to get this wrong.
All right.
Yeah.
All right. So if you didn't get this one right, you're still in good company.
Yes. I'm actually pretty sure that all my fellows will get it wrong too.
Okay.
All right. So the case that I presented is the patients with 3 foci of bone mets. And this came from this really an important seminal paper that was published in the New England Journal of Medicine in 2015 from a clinical trial called CHARTED, and we'll talk about this trial some more. So in this trial, the patients were divided into 2 categories, high volume versus low volume. And the patients with high volume disease needed to have visceral mets. And by visceral met, it's typically liver or lung. And, that's actually a very small segment of prostate cancer population, probably 5% or less. But we've always known that they had the worst prognosis. And then 4 or more bone mets, one of which should be outside of the spine and pelvis. And that's because, intuitively it should be obvious that the more bone metastasis that you have, the worse the prognosis is going to be. And the patients with bone mets in the appendicular bones, such as the arms, legs, ribs, they typically have a worse outcome than patients whose bone mets are confined to spine or pelvis. So low volume disease will be all others, such as patients with 3 or less, or lymph node met alone. So here is another difficult question that I expect probably even most oncologists not to know. So this is actually the main slide, the main teaching point of this whole lecture. So what is the treatment options available for this patient with low volume disease after starting androgen deprivation? A, docetaxel chemotherapy for 6 cycles. B, abiraterone. C, enzalutamide. D, apalutamide, or all of the above except docetaxel.
And we'll open that up so we can see the responses. And please take another 10 or 15 seconds if you've not already shared your response to share this with Dr. Wang. All right, looks like we have quite a few. Dr. Wang, how did they do this time?
Wow, I'm really impressed. Well, the correct answer is E. Abiraterone, enzalutamide, apalutamide would all be acceptable. And, actually, the docetaxel chemo for 6 cycle is, I think it's not completely wrong. I mean, you could give chemotherapy for low volume disease, but we generally don't for the reasons that were discussed. Okay, so I think that this CHARTED trial had a major pivotal seminal impact in practice of prostate cancer therapy for patients with metastatic disease. And this paper came out in 2015. And in this trial, the patients with newly diagnosed metastatic prostate cancer divided into high volume versus low volume disease, who have never received docetaxel and had androgen deprivation started 4 months or less, were randomized between the docetaxel chemo for 6 cycles versus no chemo. And this is the top line result. So the patients who got chemo had increased survival by 13.6 months. So the survival went from 44 months to 57.6 months. And then another thing to look at is this general concept of hazard ratio, well, which is essentially a relative reduction of risk of death. So there was 39% reduction in risk of death, which actually in oncology is a pretty substantial effect. Another important finding was that it appeared that much of the benefit was actually confined to patients with high volume disease. So in that group shown on the left side, the survival went from 32 to 49 months, so that's a 17-month survival advantage. Whereas in the low volume disease, there could be a little separation of the curve, but actually on longer follow-up, there was no difference in overall survival. So this trial established the fact that another treatment that's added to androgen deprivation therapy, such as docetaxel chemotherapy, was beneficial in terms of helping patients live longer. And then another real practice-changing trial came out in 2017. It's called Latitude. It took patients with newly diagnosed prostate cancer, and they were randomized between abiraterone versus placebo. And the result was that the overall survival was improved with a hazard ratio of 0.6 and much more marked effect on the radiographic progression-free survival. So this is actually the final long-term analysis of the survival that was more recently presented. So patients who got the standard of care with ADT alone and placebo lived 36 months, whereas patients who got treated with abiraterone lived 53 months, and overall increase in survival was on a median of 17 months, which is actually very similar. So this established the benefit of adding abiraterone to patients who presented with metastatic disease. And that's what I do most commonly. And then another important thing is that I feel that this is a very well tolerated drug. So the two main side effects of this drug would be hepatotoxicity, which is easily picked up by increased transaminases like ALT and AST. So there is a baseline incidence of about 4% for grade 3 or severe life-threatening increase in transaminases, and it goes to 8%, and it's reversible. So as soon as I detect it, I stop the drug and it goes away. And then another important class of side effect is something called the Mineralocorticoid excess syndrome, and it's actually intrinsic to how the drug works. So when CYP17 enzyme is inhibited by abiraterone, the body reacts by making more of mineralocorticoids such as aldosterone. So that leads to sodium retention and excretion of potassium. So as you can see, the hypokalemia goes from 2% to 11%, and then hypertension goes from 10% to 22%. And very rarely patients may develop congestive heart failure if they have weak heart to begin with. But what I observe is that the patients don't experience symptoms like fatigue, nausea, vomiting, neuropathy, all the typical side effects of cytotoxic chemotherapy. And then this year, the two trials came out that shows benefit of adding enzalutamide. So there is a trial called Arches, which I won't go over in detail. And then this particular trial called Enzamet was presented in June of 2019. So in this trial, patients with newly diagnosed metastatic hormone-sensitive prostate cancer were randomized between standard non-steroidal anti-androgen, which would be bicalutamide, which I regard to be essentially an ineffective drug, but can be used, versus enzalutamide, the much more potent anti-androgen. And they're followed, this is the overall survival impact of adding enzalutamide. So the hazard ratio is 0.67, which is very similar to enzalutamide. And then in terms of survival impact at 3 years, without the enzalutamide treatment, with bicalutamide or non-steroidal anti-androgen alone, 72% of patients were alive. But with the addition of enzalutamide, 80% of patients were alive. So there is additional 8% of patients who are alive at 3 years because of the addition of enzalutamide. I think that one of the more interesting thing about this trial was the fact that docetaxel could be given. So about 45% of the patients received docetaxel, and if you look at the right-hand side, it breaks down the survival by patients who got docetaxel. So if you look at the right here, this panel here, you can see that the two survival curves are essentially identical. The hazard ratio of 0.9. I think that what this tells me is that if you got docetaxel, if the patient got docetaxel, there is no real benefit to adding enzalutamide. Whereas in this bottom group here, in patients who did not have chemotherapy, the addition of enzalutamide did provide substantial survival benefit. So the way I interpret this trial is that one can have either docetaxel or enzalutamide. You can choose one, but there is no reason to get both as of right now. I mean, with longer follow-up, maybe this could change, but as of now, you only get one agent. And then another important thing to note is the side effect of enzalutamide. So here the table is actually reversed. So the baseline is on your left, and there is a modest increase in hypertension going from 4 to 8%. But I think that to me the real telling part is the incidence of fatigue, going from 1% to 6% for the more severe, and then moderate fatigue going from 14% to 25%. And that's pretty consistent with what I observe in my clinical practice with patients experiencing fatigue. And then another significant event is falls. So, in the grade 2 area here, you go from 1% to 5%. And for the elderly, this is something that I'm very concerned about. And then there is also the problems with cognitive faculties, concentration impairment going from 1% to 4%. And then we've always known that a few patients may develop seizures, and that's seen here. 0 patients with seizures on standard treatment versus 7 patients having seizures on enzalutamide. So this tells you that there is a completely different spectrum of side effects seen with enzalutamide compared with abiraterone. And then real quickly, let me just present this Titan trial, which actually looks at the impact of apalutamide. And apalutamide is essentially a slightly better version of enzalutamide. It does exactly the same thing. So the same patients with metastatic hormone-sensitive prostate cancer were randomized between apalutamide and placebo, and it had a big impact on radiographic progression-free survival, and pretty much the same effect as enzalutamide or abiraterone. The hazard ratio is 0.67. So at 2 years, 74% of patients were alive with placebo versus 82%, 8% gain in survival at 2 years. So this makes for a big increase in the array of options. So here is a summary of data. So the 2 clinical trials, CHARTED and STAMPEDE, which I didn't talk about, supports the idea that the docetaxel leads to improvement in overall survival. And we predominantly use docetaxel in patients with high volume disease because of the CHARTED data. And then there is both Latitude and another STAMPEDE trial arm that shows that abiraterone led to overall survival advantage. And 2 trials, ARCHES and ENZAMET, demonstrated that enzalutamide led to overall survival advantage. Actually, in ARCHES, the primary endpoint was only progression-free survival. But regardless, I think that enzalutamide has been shown to improve overall survival. And the latest trial, the TITAN trial, shows that apalutamide shows increase in overall survival as well. So how do we choose between these options? I think that obviously the first thing is to balance the benefit versus toxicity of the agent. And I think that, it's impossible to really compare across trials. But having said that, the overall hazard ratio is very similar between all the trials. So my overall take is that there is probably no difference in terms of efficacy of any of these agents. Okay, so I tend to more concentrate on the toxicity, and obviously cost is a big issue because these are expensive medications. And then you would have to take into account patient comorbidities and preferences. So I'm going to go back and redo this poll again. So what is the treatment options available for patients with low volume metastatic hormone sensitive prostate cancer after starting androgen deprivation therapy? Docetaxel chemotherapy for 6 cycles. Remember I said low volume, not high volume. And then abiraterone, enzalutamide, apalutamide, or for E, all of the above except for docetaxel.
All right, and we'll make that available now so we can see all of the responses. Certainly seem to be leaning in one direction. Take about 5-6 more seconds, if you would, to respond if you have not already. All right, Dr. Wang, how did they do this?
Oh, wow. They did excellently.
Great.
Yeah, they got the, and then, let me actually talk about my personal approach to the metastatic hormone-sensitive prostate cancer. So if truth be known, I really think that for some patients, especially those patients with poor performance status, substantial comorbidities, who are elderly, who don't want it, just treatment with androgen deprivation therapy only is still reasonable. And some patients, do choose, and frankly, I don't offer second treatment to all my patients. And then, as I mentioned before, unless there is a contraindication such as history of congestive heart failure or uncontrolled hypertension, I prefer to treat with abiraterone along with prednisone. But having said that, I think that enzalutamide or apalutamide is a reasonable alternative. But docetaxel could still be considered, especially if a patient is healthy and is young and has high volume disease, and if the patient has visceral mets. And then in some systems, not so much in my practice, there is a real severe cost constraint. And without question, docetaxel is probably the cheapest alternative. But that really depends on the price of the drugs like abiraterone. There is a generic form of abiraterone that has come into the market, and that has resulted in some cost reduction, but we'll have to see. But anyway, this is my approach. And then in the way of transitioning to another very important and probably a fairly new topic, let me present this case. Okay, so it's actually the same case, except that this time the bone scan showed 10 foci of uptake. So this patient has high volume disease, but the patient is otherwise healthy and has no other medical history. And he has completely negative family history for prostate cancer. And there's actually no history of family history of cancer, period. So the question that I have is, which of the following is true? So germline testing for hereditary cancer susceptibility gene mutation for this patient is not indicated because of lack of family history. And remember, the patient did present at age 75. So really, germline testing is not indicated. That's A. B, germline testing for androgen receptor should be done. C, germline testing for the gene APC should be done. Or D, germline testing for BRCA1, BRCA2, and ATM should be done.
All right, and let's see how they're doing. So thank you all who have answered already, and again, take another 10 seconds or so if you would to go ahead and share your response. All right, Dr. Wang, how did they do?
Well, this is a real teaching opportunity. I'm glad that I picked this topic.
Good.
Because 67% who answered that germline testing is not indicated would have been right as of 2 years ago. But now the correct answer is D, actually. Germline testing for BRCA and ATM mutations should be done.
Okay.
And let me talk about exactly why that is true. Okay, so this paper by Pritchard et al., published in New England Journal of Medicine in 2016, had another practice-changing impact. So this paper showed that sequencing of 20 DNA repair genes in germline DNA of patients with metastatic prostate cancer demonstrated that 11.8% had a mutation in one of the DNA repair genes. And here, this diagram shows the distribution of the genes that are found to be mutated. So the most common is actually BRCA2, and then next most common is ATM, next is CHEK2, and next is BRCA1, and then all the other rest make up the quarter of the slice. Now, I think that probably most of you are very familiar with the fact that patients with either BRCA1 or BRCA2 mutations, or women with BRCA1 and 2 mutations, are at a high risk of developing breast cancer. And some of the celebrities have actually publicized the fact that they've had a prophylactic mastectomy to reduce the risk of breast cancer. But what has not been known until very recently is the fact that the men with this BRCA mutations actually develop prostate cancer, and not a nice one. I mean, patients with a BRCA mutations tend to have a very aggressive prostate cancer with decreased survival. So I think it's important to identify them. And another important and interesting fact that's consistently found in genetics of prostate cancer, at least, is that there is actually no impact of family history. So you could have had an extensive family history, or you may not have had any family history, and it doesn't matter. The yield is the same, or the age at diagnosis, young or old. So anyway, if you do germline testing on all patients with metastatic prostate cancer, I tell the patient 1 out of 10 chance of finding something approximately. So the yield of BRCA2 mutation is 5.3%, ATM 1.6%, CHEP2 is 1.9%, BRCA1 is 0.9%. Anyway, and as I mentioned, NCCN guideline recommends germline testing of all patients with metastatic prostate cancer, and also occasionally you'll find these genes to be mutated from tumor sequencing, and they need to have germline sequencing done as well. And typically at our UNC practice, genetic counselor sees the patients and provide both pre and post-test counseling. But if the genetic counselor did not see the patient and then the mutation comes back positive, then they will provide post-test counseling, because if a patient has a mutation, then 50% of their first-degree relatives, such as children and siblings, will also carry this gene. So why does this matter? It actually has an important therapeutic implications. So there is this concept of synthetic lethality with BRCA deficient tumor cells. So there is an enzyme called PARP, or poly-ADP ribose polymerase, where there are drugs against it. And in normal cells, if they get treated with a PARP inhibitor, then the cells divide just fine. But in cancer cells, where BRCA is missing, the cancer cells cannot withstand the inhibition of PARP enzyme, so they actually die preferentially, whereas normal cells are not affected. And this work by Matteo et al. Showed that up to 30% of all patients with castration-resistant prostate cancer may have a mutation in one of the DNA repair genes, most commonly BRCA2, and it could be germline or somatic in the tumor cells. And the treatment with olaparib, which is a PARP inhibitor, actually led to a very high response rate. So this led to this clinical trial called PROfound, in which the patients were selected who had already been treated with either abiraterone or enzalutamide, and if their tumor had a mutation in either BRCA2 or 1 or ATM, they were randomized between treatment with olaparib versus physician's choice of either enzalutamide or abiraterone, whatever the patient had not been seen. And the results just came out in October of 2019. So olaparib led to an improvement in progression-free survival with a higher response rate and trend toward overall survival. So, I expect that this drug will be approved in a matter of few months in 2020. And now it behooves us that all patients with castration-resistant prostate cancer be given an opportunity to consider this drug, which means that either their tumor needs to be sequenced or the germline testing be done, or preferably both. So this is something that's really on the horizon. And oh yes, this is all the material that I have, and I wanted to give a point to this particular reference. A review paper in New England Journal of Medicine that actually gives a great overview of current therapeutics. It doesn't talk about the PARP inhibitor, but it talks about just about everything else. Okay, so this concludes my prepared portion, and I'm happy to answer questions now.
Great. Thank you so much. Let me go ahead and advance a couple of slides, and I think you'll see some familiar faces from Lineberger there. And then we'll open this up for questions. So at this point, if you have any questions, you can go ahead, polev.com/UNCCN, or use the app with UNCCN, or text those questions in, and we've got instructions at the top there as well. So your questions for Dr. Wang. Dr. Wang, that was fascinating about the BRCA1 and BRCA2 pertaining to men and prostate cancer. Has the insurance company kept abreast of this? Are they routinely covering that genetic testing?
Yeah, that is absolutely the most critical question. Frankly, the insurance coverage is a big issue for us, and so this is how we handle it. Mm-hmm. So it turns out that the companies are actually willing to do the test for free for Medicare patients.
Okay.
So they just write that off,
okay.
And then insurance companies. Their coverage actually really vary. Some insurance companies actually demand that they still, the patients demonstrate family history. Some don't. Mm-hmm. Some insurance companies don't cover it at all. So we have to do this sort of on a case-by-case basis. But having said that, at my UNC practice, mm-hmm. with the support from genetic counselors, mm-hmm. I found that the company that actually does the testing, they are actually willing to write off the cost of the test for patients without coverage. So I've not found this to be a barrier, but I'm actually concerned that that if you don't have access to the genetic counselor, that could be a big issue.
Gotcha. No, that makes sense.
I think that, at UNC, I feel very fortunate to have the support of genetic counselors for patients with metastatic prostate cancer.
Absolutely.
And nationally, I do see this as a huge problem where it's not actually available. But I do hear that, my genetic counselor does a lot of telehealth type of mm-hmm. thing, which mm-hmm. actually is quite effective. So, mm-hmm. so I think that, this is something that we need to be working on.
Yeah. No, that's fascinating. And I imagine it'll take a little bit of time. I know just even in my 23andMe subscription, I see that only pertaining to, unless it's changed recently, to women in terms of the BRCA1, BRCA2 testing.
Yeah. So the problem with the 23andMe mm-hmm. is that I read mm-hmm. that it only covers like 3 variants.
Right.
So you may be missing 75% of all mutations out there.
Very good. All right. Well, we've got some questions coming in, and I hope we'll have more. Could you discuss the role of radium-223 for bone mets sequencing of this modality versus the medications listed?
Yeah, excellent question. So radium-223 is currently FDA approved for treatment of patients with the metastatic castrate-resistant prostate cancer with bone mets and without the visceral mets. So with this, it can actually be given virtually at any point in the course of castrate-resistant prostate cancer. So the one concern that we do have is that the most recent trial of combining abiraterone plus minus docetaxel radium-223 showed that the combination of radium-223 plus abiraterone at the same time led to increased fracture rates. So I would be a bit cautious about giving it at the same time. But my typical sequence is to start with abiraterone, and at second line, after progression on abiraterone, I would actually offer not enzalutamide. I tend not to go from Abi to Enza, but to consider docetaxel. And I think that the radium-223 I consider to be sort of a cytotoxic treatment for the bone only. So for patients who don't have metastatic disease outside of the bone, which is about 70% of all prostate cancer patients, I think that the radium can be used before docetaxel, or the other way around. So I may go from abiraterone to docetaxel to enzalutamide to radium-223, but I think that for some patients, who are really too sick, who have very poor performance status and have bone-only disease, I think that those radium-223 as the sole or first-line agent for castrate-resistant disease is eminently rational. So I've done that a lot too. But at the end of the day, I think that my prostate cancer patients typically should get maybe 3 treatments. So abiraterone, radium, or docetaxel, and then the other anti-androgen. And I'm hoping that very soon some patients will be able to get the PARP inhibitor or olaparib as well.
Great, thank you. Another question here. I'll let you go ahead and read this one.
I think that, okay, so the question is, why do you prefer abiprednisone or over enzalutamide in light of using steroids in the elderly patient? So, this is a subjective assessment, obviously, but, I've had a fair amount of experience using enzalutamide in elderly patients, and frankly, they do not tolerate it well. I've had many patients go to the emergency room with just not being able to do anything. They can't get out of bed. They develop severe fatigue. They have muscle weakness. They may have increased falls, and I really think that the prednisone 5 milligrams a day is actually a much better deal than being exposed to all the side effects of enzalutamide. So what I tell the patients is that with abiraterone, the side effect is that you have to go to the doctor's office more often. You have to have your blood pressure monitored. You have to have your liver function test done. Whereas with enzalutamide, yeah, you may not have to go to the doctor's office, but you're getting symptoms that you can feel, like fatigue. Oh, and one more thing that I may be very important to mention, and this is the data that just came out in Lancet Oncology, is that the Canadians did a study of a sequencing of 2 anti-androgens. So they randomized patients between going from abiraterone followed by enzalutamide as soon as a PSA started to rise on enzalutamide, abiraterone as a first line, versus the other sequencing, which is enzalutamide followed by abiraterone. It turns out that the overall progression-free survival with respect to PSA rise was actually longer with the abiraterone to enzalutamide compared to the other way, enzalutamide to abiraterone. So for whatever mechanistic reasons, abiraterone does not work if a patient has been treated with enzalutamide. So, I think that by starting with abiraterone, you do preserve just a little bit of the efficacy of abiraterone, enzalutamide used as a second-line agent. Really, I just don't think that 5 milligrams of prednisone is such a big deal, unless you have, reasons where you can't tolerate 5 milligrams of prednisone very well, such as diabetes.
All right, thank you. What, if any, correlation exists between chronic bacterial prostatitis and MPC?
Well, that's an interesting question, and the answer is that I don't know. I'm actually not aware of any data per se.
And last question, will you recommend children to be tested for BRCA if dad is found to have a mutation? If kid is positive, what is the recommendation?
Yeah, that is an excellent question. Mm-hmm. So, it depends on what you mean by kid. Mm-hmm. So if you're talking about a minor, like less than 18, mm-hmm. I have some real concerns. And that is that currently there are certain protections for patients with germline mutations, but it doesn't really extend completely. So if I were 18, I don't know if I want to be found with the BRCA mutation when the real disease may not strike people until they are aged 40 to 50. But on the other hand, I stress the fact that I tell my patients who are in their 70s and 80s, and if you have a son, if you have a daughter who are in their 30s, 40s, they may, and they actually have the mutation, their children should be tested because there is a whole science, there is a whole screening guideline for women with BRCA mutation, and it's less clear for men. But the current guidelines are that if you have a family history of prostate cancer, you should start to have your PSA screening done at age 40. And there are a number of trials going on around the country, including at National Cancer Institute, that is specifically looking at the BRCA carriers. So I think that the middle-aged children in their 40s are probably better off knowing that they're a BRCA carrier. And if for me, I definitely would know if I would want to know if I have up to 50% chance of being a carrier.
Yeah, absolutely. Thank you so much. Dr. Wang, thank you for all that you do, for your expertise today, and for all that you do for cancer patients here in North Carolina. Just a couple of things to wrap up, some other thank yous. We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund at UCRF and the Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obore, and John Powell for all the work they do on this and every other one of our lectures. Coming up, the role of patient support networks in cancer outcomes with Justin Yop, and then Leukemia 2020 with Josh Seidner. Those are our next two lectures, February 12th and February 26th, both at noon. We have lectures that are going into our portal so that you can view those, receive credit for those after you take a little test at the end. Tobacco use treatment in cancer care and clinical trial update in head and neck cancer. Those are both online. Cancer Conversations coming up this Friday. No credit with this, but these are for the public and those impacted by cancer, understanding pancreatic cancer. With Catherine Hepper. We hope you'll be able to join us for that as well. And you know where to find us on the web, unccn.org, all sorts of information, and we'll be bringing your lecture online very soon for our learning portal. Again, thank you so much.
Thank you.
Thank you to our audience for all that you do, and until next time, have a great afternoon. Thank you.